Bismillahirrahmanirrahim. Assalamu alaikum. A very good afternoon to all respected guests, honorable consulting, doctor, my colleagues, and participants present here today. I'm Dr. Roxana Akhtar. I will be your host for the informative gathering. It is my immense pleasure and honor to welcome you all to today's CME program on the occasion of World Hypertension Day 2026, organized by Bangladesh Specialized Hospital with scientific partner Pekun Pharmaceutical PLC. Today's CV session focused on one of the most important global health challenge, hypertension and its evolving management, especially resistant hypertension and renal disease related hypertension. Now, with great respect, I would like to acknowledge our honorable guest and distinguished panel of experts. We are deeply honored to have with us the legendary Professor Dr. Harun Rashid Sir, Professor and Chief Consultant, Kitty Foundation Hospital and Research Institute. Our respective chairperson for today's CME session is Professor Brigadier General Dr. Mamun Musafi Sir. We are also privileged to have the special guest, Dr. Ahmed Zahid Hussain sir and Dr. Abdullah Al Shafi Mojumdar sir. Now, I would like to introduce our valuable speakers for today's scientific session, Dr. Shamin Ahmed and Dr. Ishrat Jahan Sadia. Now, I would like to invite our first speaker, Dr. Shamin Ahmed, to deliver her presentation. Please come on stage. Honorable Chairperson of this program, respected Chief Guest, Special Guest, Honorable panelists, panel of experts and consultants, and my senior and junior colleague, Assalamu alaikum. Please welcome to today's CME. And my topic is resistant hypertension, what is new? So before going into main topics, today is World Hypertension Day. World Hypertension Day is an annual event observed on May 17 to raise awareness about hypertension. It was first inaugurated in 2005 by the World Hypertension League and the International Society of Hypertension. The World Hypertension League had announced this year's theme as Controlling Hypertension Together. Before going into main topics, what is hypertension? According to 2024 ESC guidelines, hypertension is defined based on repeated office systolic blood pressure value more than 140 millimeter mercury and or diastolic value more than 90 millimeter mercury. It is recommended that blood pressure should be categorized as non-elevated BP, elevated BP, and hypertension. So this is comparison of office, home, and ambulatory blood pressure measurement for elevated blood pressure and hypertension. And regarding non-elevated blood pressure, office blood pressure less than 120/70 is regarded as non-elevated blood pressure. And elevated blood pressure is office blood pressure 120/70 to 140/90. Hypertension is defined as office blood pressure more than 140/90. In case of 24-hour ambulatory blood pressure monitoring, the reading is lower, that is more than 130/80. So now our definition of resistant hypertension. Resistant hypertension is defined as inability to control high blood pressure to office value less than 140 millimeter mercury systolic and less than 90 millimeter diastolic, despite adequate lifestyle intervention and treatment of at least 3 classes of drug. And the classes of drug should include a diuretic, the thiazide or thiazide-like diuretics, a renin-angiotensin-aldosterone blocker, and a calcium channel blocker with maximum tolerated dose. And inadequate control of blood pressure should be confirmed by ambulatory or home blood pressure measurement to exclude white coat hypertension. And in addition, excluding pseudo-resistance is a prerequisite. So what is pseudo-resistance? Pseudo-resistant hypertension occurs when uncontrolled hypertension is inaccurately diagnosed and or managed. So some causes of pseudo-resistant hypertension.
poor adherence to and persistence with treatment. White coat hypertension, this is very well known that a patient become hypertensive when doctor at office measures blood pressure, but at home measurement it is normal. Poor blood pressure measurement methods. There are some poor method like not supporting back, the not keeping arm at the level of heart, measuring blood pressure after anxiety or smoking or caffeine intake, and leg crossing during blood pressure measurement. These all may or inadequate cuff size. These all may causes spuriously high systolic or diastolic blood pressure. Marked brachial artery calcification, oscillar phenomenon. This may also record blood pressure very high, although the invasive measurement of blood pressure or the palpatory method of blood pressure shows blood pressure is actually normal. Then physician-related some factors like clinical inertia, inadequate dosing, inappropriate combination of blood pressure lowering drugs. And Munchausen syndrome is a very rare phenomenon. And then come to the epidemiology of resistant hypertension. Establishing the exact prevalence of resistant hypertension is challenging because of high prevalence of pseudo-resistant hypertension. In our meta-analysis, including data from 91 cohort of cross-sectional study comprising more than 3.2 million patients, the prevalence of resistant hypertension was about 10% among patients treated for hypertension. In other studies, varied results are formed, and it shows prevalence of resistant hypertension that is 10 to 30% of hypertensive people. You have to remember the actual prevalence of hypertension is very high. In worldwide, 1.2 billion adults have hypertension. So 5 to 10% of hypertension patients is actually very high. So the global burden of resistant hypertension is actually high. Approximately 100 to 500 million people suffer from resistant hypertension. So these are some causes of resistant hypertension, like behavioral factors. The patient inappropriate dosing, overweight, obesity, physical inactivity, excess dietary sodium intake, excess habitual alcohol consumption, use of drugs or substance that may increase BP will be discussed later. Sleep disorder like obstructive sleep apnea, undetected secondary hypertension, this is very important. All these factors may lead to increased sympathetic activity, RAS activity, increased sympathetic activity, increased RAS activity, increased activity of endothelin and vasopressin. All these factors combined causes sodium and volume retention, water retention, and ultimately this leads to resistant hypertension. So now come to some drugs which may cause resistant hypertension. Salt and water retention, non-steroidal anti-inflammatory drug, steroids, oral contraceptive drugs containing estrogen, anti-angiogenic cancer therapy, sodium-containing medication, some effervescent medication, and licorice, and non-adrenergic stimulation, drugs used for weight reduction, illicit drugs like cocaine and amphetamine, antidepressant, and some herbs. And there may be imbalance of vasoactive substance resulting in high endothelin, like cyclosporin A. Now, very important topics, secondary causes of hypertension. Most of the resistant hypertension is caused by some secondary causes. So, number one is renal parenchymal disease, then renovascular disease like renal artery stenosis, endocrine disease, they are relatively uncommon. Still, primary aldosteronism, Cushing's syndrome, pheochromocytoma, thyroid gland disorder is very common, hyperparathyroidism, obstructive sleep apnea. Sometimes we cannot recognize this very important cause of resistant hypertension. Obstructive sleep apnea, sleep deprivation ultimately causes sympathetic overactivity, RAS overactivity, and fluid and volume retention. And aortic coarctation is a well-known cause of secondary hypertension. So why we are presenting these topics? What is the clinical implication? Impact on patient and healthcare system. Very important. Resistant hypertension predispose patient to cardiovascular complication with higher mortality and morbidity. Patient with resistant hypertension has an increased risk for developing hypertension-mediated organ damage like ischemic heart disease, heart failure, stroke, CKD, and premature cardiovascular event, even premature death. Prospective studies using ambulatory blood pressure monitoring suggested almost twofold increased risk of cardiovascular event in flu-resistant hypertension. In addition, it puts a high financial burden on the patients and the healthcare system, as it needs more drugs and more official visits are required. And there is also impact on our physician because failure to achieve target blood pressure in a hypertensive patient causes frustration in physician and lack of trust in pharmacological treatment. Now come to the diagnostic workup. Crucial step is to rule out pseudo-resistant hypertension by excluding at first improper measurement technique, as I have mentioned, medication non-adherence and white coat effect. Then the patient history must be carefully recorded, including patient's lifestyle feature like obesity, BMI, alcohol and dietary sodium intake, concomitant drug history, and sleep history. We may use Epworth sleep study to diagnose obstructive sleep apnea, and the presence of obstructive sleep apnea should be checked. Secondary cause of hypertension must be checked according to patient medical history and physical examination. Then appropriate laboratory or imaging test may also be warranted. And the first line investigation should include renal function, serum potassium level, albumin creatinine ratio. Any additional diagnostic test may be needed for the secondary causes, endocrine causes, as I have mentioned earlier. And transthoracic echocardiography must be done to detect the presence of aortic coarctation. It can also detect hypertension-mediated organ damage like left ventricular hypertrophy and other hypertension-mediated organ damage needs to be investigated. These are some examples of investigation that should be done to detect HMOD, like echocardiography, coronary CT angiogram, high sensitivity cardiac troponin I, ankle brachial index abdominal ultrasound fundoscopy. This should be done according to the patient's clinical history and profile. These are also some investigation to screen for secondary hypertension. This should also be detected by patient's clinical history and examination findings. I'm not going into detail. Now, regarding treatment, non-pharmacological intervention for resistant hypertension. This is also applicable for hypertension, but for resistant hypertension, it is very important to ensure non-pharmacological intervention. So we should emphasize on taking whole grain fruits and vegetables, polyunsaturated fat, low-fat dairy product, moderate amount of fish and poultry, optimum dietary potassium intake by consuming diets rich in fruits and vegetables. It has some BP lowering effect and may be associated with lower CVD risk. We should adopt a healthy and balanced diet, such as the Mediterranean or Dash Charles diet. And what we should not do. Non-pharmacological intervention that should avoid excess sodium intake, should avoid foods rich in sugar, that is sugary drinks, sweets, cakes, cookies, saturated fat, trans fat, and excess alcohol. We should restrict daily sodium intake to approximately 2 grams or 5 per day. That is actually 5 millimole. It is recommended to stop tobacco smoking, to initiate supportive care and refer to smoking cessation programs are recommended. Moderate intensity aerobic exercise is recommended, more than 150 minutes per week or 75 minutes of vigorous intensity aerobic exercise. In addition, increase daily activity like walking, cycling, taking stairs instead of taking lifts. we should avoid sedentary lifestyle, and it is recommended to aim for a stable and healthy BMI, like 20 to 25 kg per meter square, and healthy waist circumference values, like less than 94 centimeter for male and less than 80 centimeter in women. Then, what should we achieve by lifestyle intervention? Weight reduction for 5 to 20 millimeter mercury blood pressure can be reduced for every 10 kg weight loss. And DASH eating plan, it may reduce blood pressure for up to 8 to 14 millimeter mercury. Dietary sodium restriction can cause blood pressure reduction for 2 to 8 millimeter mercury. Physical activity, 4 to 9 millimeter mercury. Alcohol moderation, 2 to 4 millimeter mercury. Now come to the pharmacological intervention. In definition, we have seen 3 antihypertensive drugs already have prescribed to define resistant hypertension, and then blood pressure control may be improved by switching chlorothiazide to long-acting thiazide like diuretics, like chlorthalidone. Or indapamide can be also given, but we should remember indapamide cannot be used or not very effective. GFR less than 30 ml per minute plus 1.70 meter square. And also, in this case, loop diuretics can be used. Well titrated loop diuretics can be used. Spironolactone is a good choice, and it is recommended as fourth drug in a dose of 25 to 50 milligram, and it should be proposed in addition to antihypertensive medication. It can reduce blood pressure by 8 to 12 millimeter mercury, but spironolactone has some problem. Again, it is not suitable when eGFR is less than 30 ml, and when serum potassium level is more than 4.5 millimole per liter. It also causes some unwanted side effect like painful gynecomastia, erectile dysfunction, this and this. So, if spironolactone is not effective and not tolerated, it can be replaced by eplerenone, but which is less potent and it also causes hyperkalemia. The addition of beta blocker is recommended if not previously added. And lastly, a centrally acting drug like clonidine, an alpha blocker, and hydralazine can be used. There are some promising new hypertensive drugs like finerenone is a non-steroidal mineralocorticoid receptor antagonist that is currently being tested as an alternative to spironolactone. ARNI, angiotensin receptor neprilysin inhibitor, we use widely for the treatment of heart failure, especially heart failure with reduced ejection fraction. It is not yet approved for treatment of hypertension, but it has demonstrated better blood pressure reduction. And SGLT2 inhibitors, also used in heart failure and treatment of diabetes mellitus, it caused 10 millimeter mercury reduction of elevated systolic blood pressure in patients with diabetes mellitus and CKD. Yes, SGLT are not indicated for only treatment of hypertension now. And some experimental drug, Baxdrostat and Lorenzostat, which selectively inhibit aldosterone synthase enzyme, is on phase 3 trial. Aprocitentan and Gilbesiran uses short interfering RNA to reduce hepatic angiotensin synthesis. It is on phase 1 trial. So last but not least, we should ensure adherence to pharmacotherapy. In case of resistant hypertension, drug or adherence, non-adherence may reach 15 to 50%. So, drug adherence should be improved by once daily using, single pill combination drugs, and uses of latest technology like smartphone apps. Renal device therapy or intervention like renal vascular denervation is gaining popularity, but it only had class 2B recommendation, and BP lowering effect is modest, only 6 millimeter mercury. This is a flow chart showing the treatment options. Office BP 140, more than 140/90 despite 3 or more BP lowering medication. Referral to hypertension center should be considered. And when true treatment-resistant hypertension is diagnosed, spironolactone can be used. If spironolactone is not tolerated, eplerenone can be used, and beta blocker should be added if previously not used. Then, if BP still remains uncontrolled, we can use alpha blocker, centrally acting BP lowering drugs, potassium sparing other diuretics, and renal intervention. So, take home messages. Resistant hypertension represents a difficult to control hypertension despite adequate drug therapy. Ruling out pseudo-resistance and investigate causes of resistance is crucial. Resistant hypertension should be managed as specialized center with the expertise and resource to exclude pseudo-resistant hypertension. Management of resistant hypertension involves encouraging a healthy lifestyle, enhancing patient adherence, and modifying or adding new classes of antihypertensive drugs. Untreated resistant hypertension increases the risk for major cardiovascular events. These are some of my references, and this is a photograph taken at Ramna Park, morning exercise, and the so-called HAHA group. They are exercising regularly and reducing stress. So we should move for stress-reducing activity and regular physical exercise. Thank you everyone for patient care.
Thank you so much. Please. Take
Oh, sorry. Yes.
Thank you so much for that excellent presentation. Now, I would like to invite our second speaker, Dr. Ishra Jahan Sadia, to kindly proceed with her presentation regarding finerenone, the emerging confidence in renal disease.
Assalamu alaikum. Good afternoon, everyone. At first, I would like to welcome you, everyone, especially our chief guest, Professor Dr. Harun Rashid sir, to be here with us, and our other consultants, experts panel, and our special guests to be here. I welcome you, everyone, and I'd like to express my gratitude to my beloved colleagues to be here and support me here. So I am Dr. Isra Jahan Sadia. I am medical officer in the Department of Nephrology, and today I am having the honor to present my special discussion on this topic, which is finerenone, the emerging confidence in renal diseases. So without any delay, I would like to start my today's session. So at first, I would like to discuss a case here. So what is our case here? We have got a patient here who is Mr. X. He is a 44-year-old man. He is suffering from type 2 diabetes mellitus for the last 20 years, and he is hypertensive for 10 years. And he has now come